amazing to putting this series together. We've had a lot of alumni come back, and just hearing the connections and how those connections have been maintained over the years. It's pretty fascinating stuff, especially when you become so close to the residents that you're working with right now. And
yeah, your buddies for 30 years, you know,
yeah,
amazing. Well, this
yeah.
this lecture grew a little bit since we started, huh?
I hope so. No, we're very much looking forward to it. It's been an exciting time for us residents in terms of you know, our educational or at least our didactic component of our education. But yeah, we're all getting antsy to get back.
Yeah, everybody's going to have to do fellowships so they can learn how to operate.
Yeah, exactly. Exactly. Especially, I mean, New York City, everything's getting better, but it's still, you know, the
yeah, you guys have it pretty bad there.
Yeah.
We're you know, being in a children's hospital, we're fairly protected. We just started elective surgery yesterday.
Oh wow.
But coming in at kind of a slow rate.
Sure.
You know.
They had to convert our children's hospital. I mean, I think the ORs are closed, and I don't think they're going to open the children's hospital. It's not going to be one of the first to open.
Yeah.
But children, at least the entire hospital, the children's hospital hasn't been affected as badly. They just need to reorganize and restructure that hospital to handle the adult.
Yeah, you know, they didn't, ours is a freestanding children's hospital, so we didn't have to do anything really. We thought that we would have to give up space and units and ventilators, and none of that happened.
Wow. I mean, that's
yeah.
Yeah.
So what year are you in?
I'm a second year. Yeah, I'm almost at the end of our second year, going into third year soon, and yeah, looking forward to it. I grew up in New York, so I've kind of been a East Coast native for a long time. I like schooling in New York all throughout my life. So
where did you go to school?
I went to undergrad at Cornell. I actually went to grad school too, but I went to undergrad at Cornell, grad school at the University of Maine, and then med school in Connecticut. But I'm a late bloomer. I played soccer in college, and I went abroad to play for a little while, and then came back after. So
I'm a big soccer.
Oh yeah?
Yeah. I'm hearing echoes now from my voice. That went away. Okay. So yeah, no, we all my kids played college soccer.
Oh yeah? Where did they go?
My middle son went to Ohio Wesleyan on a scholarship the year after he won the national championship. Hated the school and transferred. And then my other son went to Tulane. Nobody played like Division I.
Okay.
But I have great connections in Brazil, and gave a webinar last night to my buddies there, and it's all about soccer in Brazil. So we were big Ronaldinho fans.
Oh yeah, of course. I used to be a big Brazil fan growing up during the World Cup days of Ronaldinho, Ronaldo, all those guys. Is Ohio Wesleyan, do they play Ithaca College?
I think so.
Okay, I thought so. My brother, so when I played at Cornell, my brother played at Ithaca College at the same time, and I remember, I vaguely remember them playing each other, I think.
Yeah.
Which is.
Yeah. So so I had a poster of Ronaldinho in the background when I had my talk last night. Go solidarity.
You can put it up right now too. Don't hide it.
I'll keep it more professional. I even have a tie on today.
No, we don't.
I'm not wearing shoes, but that's different.
Dr. Kirsch, we'll wait at least like a few more minutes just to let.
Okay, and I have about the hour.
Yeah, exactly.
Okay. You just tell me when. Is there going to be an introduction, or do I just go?
Yeah, no, I'll definitely introduce you. And at the end, the way we've been doing it is people post questions in the chat function just because it's muted throughout. And then we'll just go through the questions at the end, if that's okay.
Yeah, that's fine. That's fine. And then is it mostly residents on?
No, so it's residents and faculty, mostly across New York residency programs, but even from across the country and abroad. So we've had people from other countries tuning in, and we've had faculty from faculty and residents from across the country tuning in too. So initially started as a Columbia series that expanded to New York. Now it's just open to whoever wants to listen.
Yeah, that's good.
Yeah. So it's been great. And I hope I kind of, we use social media to insert the lecture series, and I try to, or at least the people who manage the social media, who have the greatest influence, try to include the programs like the Emory program, or, just so they're aware. So I hope they can tune in too.
Yeah.
We have Dr. Cooper here.
Hi, Andy. How are you?
How are you?
I'm good. You staying away from the tattoo parlors?
Yeah, I'm gonna get a tattoo tomorrow. Get my hair done, my nails done, go bowling.
Excellent.
Yeah.
Is your whole family home with you?
I have my oldest son is engaged and living in New Orleans.
Uh-huh.
And he's
Mazel tov.
third-year medical student there. So.
Oh, really?
Yeah.
Uh-huh.
I sent him the link. We'll see if he gets on.
Too early if he's not quite a doctor yet.
Correct. Yeah.
The other two are home.
Are you at home?
Yeah, I'm coming in this morning now, so I'm going to watch you and then I'm going to drive in.
Okay. Cool.
So.
Yeah, we've been doing telemedicine. I've become the expert in telemedicine over the last 2 months. So
Yep.
I've been doing a lot of webinars on telemedicine.
Yeah, you mentioned that.
Yeah.
Quite an important thing right now. Hopefully it's going to really change the way we do things.
Yeah. We'll probably come back to some version of it, I hope.
Yeah, I hope so too.
We'll see.
You've met Julia Finkelstein, right?
Uh-huh.
Yeah, she's been speaking a lot about that too. They've been publishing about it the last couple of years at Boston Children's.
Yep.
So,
Yep. She's joining you. She's joining you guys, right?
Yeah, she's coming back in a few months.
Yeah.
Yep.
We're in the AAP together.
Oh, okay.
Yeah. So.
Yeah, Julia's great.
Yeah.
And did you hear that Terry gave us a lecture a couple weeks ago on Zoom?
Oh, he did?
Yeah. Christina Carpenter helped him figure it out. It was very funny. He sent an email saying, "I feel so accomplished. I mastered Zoom." It was funny.
You remember Joran Lackren?
Yeah.
The Swede that used to come every year. Yeah, we're having same type of webinar series, and he's going to be doing it from Sweden.
Yeah, I think it's great. I'm so impressed with Zoom. 150 people generally are tuning in for this, and it never crashes. It's incredible.
Yeah.
Yeah, and I told you I spoke at Sinai yesterday with Carl Olson sitting there. I mean, it's in his living room. It's great. with a little. Nope, nothing visible. 7 in the morning, maybe a little early.
All right, Dr. Cooper, is it okay? I'm going to introduce Dr. Kirsch, and we'll get
yes, please.
The webinar. Thank you, everyone, again for tuning in to our Empire Lecture Series. It's been a great great to see so many included and listening in. If you haven't, or if you've missed any lectures, please go to the New York State AUA section website, and all of the previous lectures are posted there. They're great study tools, and there's surveys as well. So please, if you have time, fill it out and let us know how we can improve. We are very fortunate to have Dr. Kirsch with us today. It's an honor. He was, he originally started his residency here at Columbia. He was, chief when our chair was in his residency program, and when our program director, Dr. Cooper, was in medical school. So there's a very long connection between our faculty and Dr. Kirsch, originally from Long Island, and has just had such a prolific career here and into his fellowship at CHOP, and now at Emory. He's currently a professor of pediatric urology at the Emory School of Medicine, and director of the Pediatric Robotic Surgery Program. we thank you so much for coming and providing us a talk on, the management, grading, and minimally invasive treatment options for VUR. So I'll pass the mic over to you, and thank you again for joining this lecture series.
Okay, well, thank you so much. The pleasure is really mine. It's been, a great ride starting off in New York and then moving to Atlanta. I've been here for 20 years. I started off doing a lot of research. It's something that I've enjoyed and I've done my entire career. So I'm going to share with you my experience with reflux, and I'm going to focus on its changing management over the years. We've developed some novel grading systems for it, and also discuss minimally invasive treatment. So let me start off with a patient. This is Hensley. This is a 2-month-old girl who presented with fever after her immunizations. Soon after that, her parents reported that in the past, during pregnancy, there was antenatal hydronephrosis. She was placed on antibiotic prophylaxis, but really with no history of any clinical problems, and what was thought to be a relatively normal ultrasound as a newborn, nothing was done. So she presented to an outside hospital with fever. They sent off a urine specimen, which showed white cells, leukocyte esterase, and bacteria. And because they were unable to get IV access or get any blood work because of this, she was then transferred to Children's Healthcare of Atlanta, where I work, for further evaluation. So she presented to our emergency room, where she was well appearing and not anorexic. Her urine was consistent with an infection. A culture was sent and she was treated with antibiotics and Tylenol. Well, the ER doctor there then consulted with the referring doctor from the outside hospital, and they said because there was minimal hydronephrosis, they spoke to the family and the primary physician again. They thought it was so subtle that they didn't have to do anything further. The patient was sent home and antibiotic prophylaxis was stopped. So 3 weeks later, she presented back to our hospital with an additional febrile urinary tract infection. She was restarted on her antibiotic treatment and then put on antibiotic prophylaxis. And we went ahead and ordered an ultrasound and a VCUG. And here are the findings. So you can see in the left kidney, there's some mild pelviectasis, some mild hydronephrosis. And then if you look at the bladder, everything looks fairly normal, except that there's a small area here, which represents a dilated left ureter. And then the right kidney was completely normal. So based on the history, not so much the ultrasound, but based on the history, we went ahead and got a VCUG. And what I want to point out here is that as the bladder fills, very early in the filling cycle, you could immediately see reflux into the left ureter. As the bladder fills, you see high-grade reflux on both sides. And this, what you see here, is called intrarenal reflux. Intrarenal reflux is associated with high-grade reflux, is associated with breakthrough infection, it's associated with renal scarring. So we got a renal scan, and the differential function showed that the left side had 35% and was pretty much a scarred kidney with a pretty normal looking right kidney. So in order to provide some perspective and context to my talk today, I'm going to ask 5 questions. The first is, why is reflux diagnosis important? The second is, what factors predict resolution? Who needs treatment? And what are the trends in anti-reflux surgeries over the years? What is minimally invasive in children? What defines success post-op? Is open surgery better than other options? Where does robotic surgery fit in? And finally, what do parents want for their children? So why is reflux diagnosis still important? Well, there's associations and consequences. One of the consequences of having recurrent pyelonephritis is renal scarring, hypertension, impaired somatic growth, and renal failure. But so too is the association of congenital renal dysplasia. Congenital renal dysplasia means that the kidney doesn't develop normally in utero, and that is also associated with these findings. The patient who probably has the worst outcome is the boy who's never had a urinary tract infection who has bilateral grade 5 reflux. That's not who I'm really going to talk about today. I'm going to talk more about acquired scarring and acute pyelonephritis. So the AUA 10 years ago published the reflux guidelines. And basically what they show is that reflux is a risk factor for pyelonephritis and renal scarring, that antibiotic prophylaxis, while being safe, is not well tolerated by parents or accepted, and it has limited long-term benefits for low grades of reflux, namely grades 1 and 2. Anti-reflux surgery has been shown clearly to reduce the risk of febrile urinary tract infections. And finally, bowel bladder dysfunction and moderate to severe grades of reflux were significant risk factors for recurrent infection and scarring. So in talking about bowel and bladder dysfunction, it's important for you guys to know when you sit for your boards is the role of bowel and bladder dysfunction and infection and reflux. If you look at the results that were published in the Journal of Urology that looked at bowel bladder dysfunction, risk of UTI versus patients without bowel bladder dysfunction, you can see that the risk based on these forest plots is a lot higher if a patient has bowel bladder dysfunction compared to if they did not. That is also true with the resolution of reflux, which also impedes the resolution in patients with bowel and bladder dysfunction. In 2011, the AAP published UTI guidelines, and there were 7 action statements, one of which was that febrile infants with their initial febrile UTI should undergo a renal and bladder ultrasound. But what got the pediatric urology community upset the most was that the VCUG was no longer considered something that was useful in the evaluation of the febrile infant with a positive urine culture. And this was based on the premise that most reflux need not be treated. So we looked at this pretty soon after the publication of the UTI guidelines. We wanted to ask, what was the difference between the patient presenting 6 months before the guidelines were presented and 6 months after? And we looked at children that were ages 2 months to 2 years that presented to the ER with their initial first febrile UTI. And we chose this age group because this was the age where the AAP UTI guidelines were applied to. And what we found was very interesting. First of all, in the cohort before the guidelines, the use of renal bladder ultrasounds was not 100%, it was about 75%. But after the guidelines, this went down significantly. We concluded that the physicians were really not utilizing sonograms as they should. Just hide. Okay. So what was also important was that by design, VCUGs were shown to drastically decrease. So if you look at the cohort before, 72% were getting VCUGs, and that dropped down to 31%, and that was significant. So VCUGs drastically decreased. Again, that's really by design, but the risk of reflux and severity was unchanged. The physicians were following these guidelines, but importantly, the abnormal ultrasounds did not predict whether patients had reflux, and they did not predict whether or not they had severe reflux. So let's talk about factors that predict resolution and clinical risk in patients. A pediatric urologist looks at patients kind of like this pie chart here. We assess the risk of febrile UTI. We're typically seen with a patient with a first or second infection. Then we ask, what is their risk of having another one? So you can see that reflux really just makes up one of 9 risk factors, but it's a very important risk factor. Other factors include anatomic abnormalities, antibiotic resistance, renal scarring, foreskin in boys, bowel bladder dysfunction is a very important one, the age of the patient, UTIs beget more UTIs, and that's an exponential curve. As after you get past 2 or 3, the risk goes way up, as does scarring. And then the genetics of the family, the patient, and the bacteria. We take these risk factors and then we decide, is this a patient that really doesn't need any treatment? We observe them. Do they need antibiotic prophylaxis? or do we offer them some kind of surgical therapy? So let's talk about grading. The international grading system has been published since the 80s, and it basically is divided between 1 and 5. Low grade is grade 1 and 2. Grade 3 is moderate grade, and grade 4 to 5 is high grade. The grades moderate to severe reflux typically will get referred to a urologist. The low grade reflux patients may not be treated at all, and those typically will not come to us. What's important about this grading system is that there's a lot of error with it. So in the largest study done to date, the River trial, which I'll go over a little bit in a few minutes, they found that 28% of VCUGs were found to have disagreement between expert radiologists as part of this study. And this error really occurred with grades 2, 3, and 4. So you could say, well, that means that grades 1 and grade 5 are the ones that we could get right, whereas there's going to be an error in the middle. And that makes sense that the error would be in the middle, and probably the error is mostly with grade 3. So if you look at resolution rates, you could ask, well, maybe this is too basic. This graph these graphs show that as time goes on, this is a 5-year period. If you have high-grade bilateral reflux, really that's not going to go away. If you have low-grade reflux, it will go away, but it may take many years. Today, parents don't want their children on antibiotic prophylaxis at all. The concept of being on it for 5 years is really in the past. And Terry Hensel's data years ago showed that the compliance with antibiotic prophylaxis based on prescription refill data was less than 20%. And so when we look at these curves and you say, yes, you have low-grade reflux, in a year there's a 50% chance it will still be there, a lot of parents would want some type of intervention, even with the low grades of reflux. So those patients tend to either have no treatment or go on antibiotic prophylaxis. But look at grade 3. Grade 3 seems to be all over the board. I'll point out that if you are an older child with bilateral grade 3, then it tends not to go away. But if you are a younger child with unilateral grade 3, it tends to go away kind of like grade 2. So, this is all over the board. I think it points out that we're not very good at grading, and maybe a lot of these grade 3s aren't grade 3s, but it also shows that the system may not be perfect. So how can we do better? How can we look at the patient, assess their risk, look at their VCUG, and come up with a better way of determining their resolution rate? So we did this several years ago. In 2014, we published a novel grading system called the VUR index, and it was used to predict the resolution or significant improvement in children with reflux that was primary reflux. We do a lot of VCUGs in Atlanta. In this study, we're looking for children that were diagnosed before age 2 with at least 2 VCUGs by age 3. So we start off with 10,000 VCUGs over a 4-year period. After we went through our inclusion and exclusion criteria, we were only left with 229 children. And I'll point out that the urologists weren't the ones ordering these VCUGs. It's mostly done by the pediatricians. So a couple of interesting findings. First of all, most reflux occurs during the filling phase of the bladder cycle. And so if you look at early filling and late filling and voiding, 86% will happen during filling. Only 14% happens during the voiding phase. And this is just to illustrate what early filling looks like. And I showed you that on the case before, but this is presumed to be low bladder volume, low bladder pressure. And so the timing of reflux, as I'll show you, is just as important or even more important than the grade of the reflux that's ultimately shown on the VCUG. This is an example of voiding only reflux, presumably high bladder pressure and high bladder volume. So the first question we'll ask then is, does the timing of reflux on a VCUG correlate with the radiographic grade? And so if you look at this information, you can see that if you just looked at the green, which is voiding reflux, almost all patients that have low-grade reflux, which is grades 1 and 2, that's the only place where you see voiding reflux. If you look at grade 3, very few of them will have voiding reflux. Let's look at early filling reflux. Yes, early filling reflux can be seen with any grade of reflux, but it is most significant in patients with high-grade reflux. So voiding only, mostly low-grade, early to mid-filling, mostly high-grade. Next question is, can the competency of the ureteral orifice be determined endoscopically? In other words, if you look in the bladder, if you direct fluid at the ureteral orifice, and I'll go over what hydrodistension is in a minute, you could see that the external portion of the tunnel opens. You could see the internal part of the tunnel open. And if you see both open, that's a very incompetent ureter. That's the one that we see associated with reflux. So here's the hydrodistension grading system. If you hydrodistend and the water that is attached to that cystoscope is hung pretty high, you know, we walk into the room, we don't really change it. It's probably 80 to 120 centimeters high. It doesn't really matter. You can't make a normal ureter open even with high pressure. So if you go through the grading system, non-hydrodistension is H0. If the ureteral orifice flutters, it's an H1. If you could see into the tunnel, but you can't see out the bladder, it's an H2. And then the highest degree of hydrodistension is when either you could put your scope up the ureter, or you could hydrodistend and see both the internal and external orifice. So this is kind of a busy graph, but I think it's really important, and I think it illustrates some of the problems we have with grading. Let's just look at what we have here. So what we have is a control group. This control group is 100 patients who have never had reflux and they've never had a UTI. From 0 to 5, these are patients with reflux. 0 means that they have reflux on one side, and this is their non-refluxing contralateral ureter. Let's just look at the H3 ureter. Again, that's the one that opens up the most. H3 ureters could be seen with any patient with reflux, even in the non-refluxing ureter. But as you go up in grade of reflux, the degree of H3 ureters increases substantially. And what I want to point out is that the non-refluxing contralateral ureter in a patient with reflux is different than a control ureter. And this is why a lot of pediatric urologists feel that reflux is a bilateral disease. And so you could conclude from this is that all patients with reflux have hydrodistension, and higher hydrodistension is seen with increased grades of reflux. The next question is, does the timing of reflux on a VCUG correlate with hydrodistension grade? In other words, if you have a patient after their first VCUG, you see early filling reflux, can you expect that they will have a H3 ureter? Can you determine the competency just based on looking at a picture on a VCUG? And I would say absolutely yes, you can. And so if you look at patients with early filling reflux, the H3 ureter was found in over 80% of cases, and therefore the vast majority of early filling reflux is associated with an abnormal or incompetent ureteral orifice. So what has happened to VCUGs over the years? Well, if you look at this period between 2004 and 2008, VCUGs were kind of going up. This is the time where endoscopic injections started to become popular, and I'll show you some national trend data on that as well. In 2008, 6 key articles that went into the AAP UTI guidelines were read and adhered to by pediatricians. These are the studies that showed that maybe reflux wasn't so important, that VCUGs weren't necessary. And look at the drop. And when the AAP UTI guidelines were published, it didn't drop substantially anymore. It just continued to drop at the same rate. So with fewer VCUGs, we could then ask, can we improve the data? And I would say that reflux is kind of like prostate cancer. You know, we've always considered this the prostate cancer of children because, you know, it's targeted by guidelines, and some of it doesn't need to be diagnosed or treated, but some of it really better be diagnosed and treated. It's the same thing with reflux. So can we improve our data? Maybe grade, as we know it shouldn't be used because maybe its importance should be questioned. And so what we did in this VOR index study is we looked at the effect of having ureteral or periureteral anomalies. What I mean by anomalies in this case are 2 things: periureteral diverticulum or a complete duplication anomaly of the ureter. Okay, so if you look at those patients, if you have anomalies, a patient has about a 24% chance of resolving their reflux over the next 2 years. If you look at grade and you just divide this between high-grade reflux or no high-grade reflux, 14% of patients with high-grade reflux will resolve or improve over the next 2 years. And if you look at timing of reflux, if you have early filling reflux, you had about a 15% chance of resolution, whereas if you had late filling, it went up to 60%. So early filling reflux is a very, very important risk factor. And this was all based on multivariate logistic regression and confirmed by a neural network model. So what could we say here? Okay, so if the VOR index is this, so this is kind of the VOR index money slide. If you look at the scoring system, it goes from 1 to 6. You get 3 points against you if you have early filling reflux. Later filling reflux is 2, voiding only reflux is 1. If you have anomalies, it gives you 1 point. If you have high-grade reflux, it gives you 1 point. And if you're a girl, you get 1 point against you because boys tend to resolve their reflux faster. So how do you get a 1? A 1 is basically a boy with voiding reflux and no anomalies with low-grade reflux, as I said. So that case, is not a high-risk patient, perhaps. And 6 is usually a girl with early filling reflux, high-grade reflux, and anomalies. So let's go back and look at our patient Hensley, not to be confused with Hensel. This is a patient that has early filling reflux, so she gets a 3. She has no anomalies, gets a 0, has a high-grade reflux, gets a 1, and as a girl, gets another 1. So that's a total of 5 out of a total of 6. Now, if you look at the data for resolution, you can see that a 5 or a 6, those two act the same, is less than 10%. And in this study, you can see that if you have an index of 3 to 6, your chance is on less than 50% that you will resolve or significantly improve your reflux. After we published this, we wanted to develop a validation cohort group. So we added more patients from Atlanta, and then we added patients from Iowa. And one of my colleagues, Chris Cooper, and my former fellow, Angie Arlen, combined to put our data together. And so we have the initial cohort resolution curve, and then we have a validation curve. And you can see that VOR index was highly associated with time to resolution, and we therefore validated this in children less than age 2. Mike Garcia, one of my current partners, and was when he was a fellow, we looked at the same data for kids over age 2. So this actually went up to age 17 or 18. So you can see the curve exactly follows and mirrors the curve that we showed before. So VOR index works for all ages. The Iowa group, Chris Cooper and others, showed that early filling reflux on urodynamic studies, and that was defined by less than 35% of predicted bladder capacity, was significantly associated with breakthrough infections. And they also showed that a dilated ureter, and they measured the ureters on VCUGs, was also associated with this. So we thought, well, is it possible that a high VOR index would also correlate with increased risk of febrile UTI? Because remember, everything I just showed you about VOR index was designed to show resolution, not risk of infection. So the Iowa group then went ahead and published about ureteral diameter ratio. And what that is measuring the ureter in the pelvis and then standardizing it to the size of the patient by measuring the distance between the vertebral bodies of L1 to L3. And this is something orthopedic surgeons do to kind of standardize patient growth. And so this was an objective way to predict clinical outcome. And we joined forces with Iowa again and to try to validate the UDR for predicting spontaneous resolution. And what we show here is that as your ureteral diameter ratio increases, so does the predicted probability of a breakthrough UTI. And so we could ask then, what is better in predicting spontaneous resolution and breakthrough febrile UTI for that matter? Is it grade that everybody has been using since the 80s? Is it the VOR index, which we described several years ago? Or is it UDR, measuring the ureteral diameter? And so we did that study. We got together with our colleagues in Iowa. And at this point, Angie Arlen was at Yale. So we had 3 institutions now. And we had 139 children and we followed them for about 3 years, and you can see their international grading distribution shown here. And what this showed is that breakthrough UTI was predicted best with the VOR index, better than UDR, but importantly, both of these systems were better than grade alone. If you look at the radiographic resolution or improvement, the UDR was better than VOR index, but again, both of these systems were better than grade alone. So we concluded that, therefore, that the international grading system was a relatively poor predictor of both of these, resolution and a predictor of infection. And given the significance of UDR, we're now going to incorporate that, and this is something done right now. We're going to come up with a new multivariate VOR index model and put it on the internet, an online calculator. Let's talk briefly about antibiotic prophylaxis, because this is something that has clearly changed over the last several years. In the past, it was common practice to use antibiotics for all children with any urinary tract abnormality, including reflux. And over the last decade or so, the policy has changed because of poor scientific data. In other words, no prospective randomized controlled trials. And it's interesting to note that 100 years ago, Sir William Osler said, "The desire to take medicine is perhaps the greatest feature which distinguishes man from animals." He went on to say that one of the first duties of the physician is to educate the masses not to take medicine. So the AUA reflux guidelines I referred to earlier basically said the efficacy of antibiotic prophylaxis could not be established, and this was owing again to significant limitations in studies that looked at this question. And so if you asked who doesn't need to be on long-term antibiotic prophylaxis, well, maybe that's easier. The patients with high-grade reflux, the ones with duplications, the ones with diverticuli, maybe partial duplications in high-grade reflux. I think these are easier cases to know what to do. In these cases, resolution is unlikely. There's a high prevalence of renal scars and dysplasia. There's growing concerns of daily antibiotic use. Parents and urologic surgeons prefer to operate. And in this case, you just fix it. So you could then ask who needs antibiotic prophylaxis. So I think this is really a process of elimination. So if you just kind of take out the patients with high-grade reflux, the patients with anomalies, the girls with low-grade reflux, boys with grade 1 to 3 reflux, most circumcised boys, who are you left with? Well, you're left with girls with grade 3 reflux. So that's the real debate. Do you put them all in antibiotic prophylaxis when 80% will not get another UTI? Or do you use a strategy where you could predict who needs it? The ones, maybe the 20% that are at risk for UTI. And those are the ones with bowel and bladder dysfunction, the ones with renal scarring, and the ones with a history of recurrent UTIs. A very interesting New England Journal poll was done in 2011, again, and this is the year that the UTI guidelines were put out. And this was a kind of generic patient of a 6-year-old girl who is otherwise clinically well. She's had several febrile UTIs, but she's been observed off of antibiotics for 3 years. And the question to these experts, the first was Alejandro Hoberman, who was the PI for the River trial. They asked, how would you treat this patient? And he said that, that studies casting doubt on the value of antibiotics were underpowered, and that the River study will prove me right. And he says, put that patient back on antibiotics. Linda Shortliff, who is a pediatric urologist from Stanford, was also on the AAP UTI committee, said you could either fix it now or fix it later. It's your choice. So she was pro-choice. And then for Dr. Uri Alan, who is one of our colleagues, a pediatric nephrologist from Kansas City, he said, if she gets infections, then fix it. Otherwise, you should observe this. So that's using logic. Now, what are clinicians doing? This was the subsequent question. They asked over 1,000 people in 82 countries who they agreed with. And you could see that logic, which means observation until there's a problem, and freedom of choice beat out scientific discovery pretty badly. And so let's talk about the River trial, because Alejandro Hoberman, who did this study, it was the largest study and probably maybe the last study of its size to be done. It was a double-blind, randomized controlled trial comparing Bactrim to placebo, 607 children. And what it showed basically is that if you had placebo, you had about a 24% risk of getting a breakthrough infection compared to the lower risk when you're on antibiotic prophylaxis. And this was greater if the infants had an initial febrile infection versus a symptomatic infection. If they had voiding dysfunction, and resistance, as you can imagine, was a whole lot worse in the antibiotic patient population, 63% versus none, about 20%. And scarring wasn't shown or really powered to show a difference. Let's talk about trends in the management of reflux. This is a study that Mike Garcia did in 2017 when he was a fellow. And I want to point out again the time period, 6 articles that went into the UTI guidelines, and then the publication of the guidelines. So if you look at these curves, you could see that we were kind of moving along pretty nicely with open surgery and deflux and robotics until the guidelines were published, and then all surgery just dropped substantially. So this has now become a new challenge to surgical education. I mean, the COVID-19 is pretty bad, right? You're getting some really good didactics, but you may need to do a fellowship to learn how to operate. And so this is, reflux was really the operation that created the field of pediatric urology. Reimplantation is a great operation. It's highly successful. You can learn to do it quickly. But when endoscopic injection came along, and as you can see by my bias, which is primary surgical treatment for reflux, you could see that with fewer referrals now, you need to get good at these procedures. It'd be nice to be able to get good at all of them, as I'll conclude at the end. But endoscopic injection is typically the way I've been going since I started doing deflux in 2001. And I've had nothing from my research and reviewing the literature that has really made me change my mind about that. So if you do endoscopic injection, sure, you can go ahead and do open surgery, you can do robotic surgery. But I look at robotic surgery as a replacement for open surgery, not so much a replacement for antibiotic prophylaxis or for endoscopic injection. And so when in 2001, deflux was approved by the FDA for primary grades 2 to 4 reflux. Now, Joran Lackren, who is a colleague of mine, a very good friend of Terry Hensel's, when I was a resident at Columbia, Joran and Arne Stenberg were the 2 Swedes that would come every year. And so I had a relationship with these guys through Terry Hensel, and I was able to become the first US site to use deflux. So we were the first ones on this side of the globe to do deflux injections since 2001. Now, for those who don't know what deflux is a very safe product of 2 naturally occurring sugars. Hyaluronic acid is a ground substance found in everybody's tissues, and dextranomer. Dextranomer is safe, and this product, this combination, has been used for 20 years in over 40 million procedures. Not all deflux for reflux. A lot of this is for facial plastics, but this remains the only agent available in the US in 2020. So what procedure was done? Well, this is called the Sting procedure. Barry O'Donnell and Prem Puri, who are listed here in this reference from 1984, they were the ones that came up with the Sting procedure. The Sting procedure stands for subureteric Teflon injection. So if you look to where they put the needle, they're injecting into the detrusor muscle below the ureteral orifice. So this is kind of what I was looking at when we sat in Washington at the FDA meeting with everybody that was going to be on the trial. And I turned to Dr. Lackren and I said, we have a 70% success and reflux is the only risk factor. Why don't we be more aggressive about this treatment and risk obstruction? We do it for open surgery. It has about a 2 to 10% chance of obstruction, and our success rate's like 95%. So how can we make this procedure better? And so we came up with this procedure pretty quickly after. So 2001 is the first time, we did injection. And here you could see the modification. The modification is now doing hydrostension of the ureter and placing the needle into the floor of the ureter. And as you inject, the deflux will then raise the floor to the ceiling, and then with further injection, it will then go around the ureteral orifice. And this provides optimal coaptation of both the tunnel and the orifice. And if there is migration or loss of volume, which have been shown to happen, then perhaps you'd still have a good effect from it. So here's the experience. When I started doing deflux, I said in 2001, I was collecting patients and families for the year before it. And so myself and one of my partners, Hal Schurz, we had 100 patients on a waiting list. And so when deflux came along, we said, we have never done this before. We're going to keep our data together, but we're going to see if we can make improvements in the technique. And we told families that we probably just look at it like it's 50-50. And after the first 20 patients, we had a 60% success rate. So we were a little bit happy, but obviously not satisfied because the gold standard is open surgery, and that has a 95% success rate. So how do we get there? So here's the sting, 72% success, no different than it had been for 20 years with Teflon. During the next period, which happened pretty soon after, we kind of felt like this wasn't good enough, changed the technique to the intraluminal injection with submucosal, and that's called the hydrodistension implantation technique, compared it to the sting, and you can see it was 90% versus 74%. So we felt that now we have a really good technique, but obstruction wasn't happening. So why don't we get more aggressive? And then we went on to the double hit technique, which I'll show, which is 2 tandem injections, more proximally in the ureter and distally, until you get total coaptation with good volume. And with this technique, since 2006, we've had a success rate over 90% with all these publications. So what is the double hit technique? For those that are interested, there's a YouTube video, but it's a tandem injection. The first one is proximally, the second one is distally. And so you'll go from having kind of a hydrodistending ureter to a non-hydrodistending ureter. This technique, by the way, when Joran Lackren and I published the experience based on a survey of the US doctors, 92% were using this technique. And here's just to show what a normal ureter looks like. You hydrodistend it, you place the needle in, you do double injection, and at the end you have the appearance of a nicely coapted tunnel and orifice. So let's look at the success rate. In 2012, we looked at our clinical and radiographic results, and we wanted to define success in several ways, but if you just look at a negative VCUG after treatment, you could see that the success is very good after one treatment. And I just want to point out that I've always defined success as one treatment and no reflux. If you look at the European data, a lot of this is 1 to 3 treatments. Some of it is going from dilating reflux to non-dilating reflux. So it's very important to point that out. So over 500 ureters, you could see my success with grade 4 reflux wasn't any different than grade 1 or 2. What's different? The difference is that the low grades of reflux have lower hydrodistension. The higher grades of reflux tend to have higher hydrodistension. And as I'll show you, this ureter requires a different technique than this ureter. This one requires more volume to get to that success rate. This was a very interesting paper that was published in 2010 by my colleague Jonathan Ruth at Duke. And when he was a fellow in Boston, he basically asked this question of about 30 different programs in urology across the country. He said, if you have a 5-year-old white female with bilateral grade 3 reflux, what is the likelihood that you'll do a deflux injection on that? And you can see the range from less than 10%, to all the way up to almost 90%. When I asked him about this data, I said, where's Boston? He said he had to exclude Boston because they were 0. And I said, where's Atlanta? And he said he had to exclude Atlanta. So this is pretty much all the programs between probably the least aggressive program with deflux to the most aggressive program. And so let's define success. I remember very clearly Carl Olson, Terry Hensel, Mitchell Benson telling me that you don't treat x-rays, you treat patients. And I think you have to apply that today as well. So do you define it by no reflux on an x-ray, or do you say, well, you had a patient with febrile UTIs and now they don't? Shouldn't that be how we define success? And so we did that. We looked at 9 ways of defining success. If you look at success, meaning that you had a negative VCUG, yes, we did very well. If you look at success, meaning that you didn't need to do open surgery, yes, we did very well. If you look at success as no febrile UTIs after one injection, which I believe should be the way you define success, yes, we did very well. And so you could define success how you wish, but clinically probably is the best way. So let's look at some data. This is a study that we looked at children who had delayed VCUGs. We actually wanted to know what their success was at a year on a VCUG. Now, as you could imagine, families that are, whose children are doing well, do not want to come back for a VCUG. So we got 50%, which we thought was good. So we had 50% with a VCUG, 50% with an early VCUG, and then 50%, as I say, with a one-year VCUG. I'll point out that 100% of our patients that we're treating had febrile UTIs preoperatively. So when you look at the clinical success rate, and again, clinical success is defined by no febrile UTI after one treatment with deflux. So 93%, if you look at the radiographic success in those patients that came back at a year, it was no different than the success rate of the patients that came back early, 93%. So with good success and long-term experience, we asked, well, we stopped doing VCUGs after open surgery years ago. Can we stop doing it after deflux injection using the double hit technique? And so we looked at 222 children, mean age of 4. All these patients had pre-op febrile UTIs. Half the patients had a post-op VCUG, half did not. Only 4% required any additional surgery, not just open surgery, but deflux. They very rarely are doing second injections. We followed them for 3 years. And what we found is that for the entire cohort of 222 patients, 94% after one treatment had no further febrile UTIs. If you look at the patients who had VCUGs, the VCUG success rate was 90%. The entire cohort of patients with and without VCUGs had a 97% chance that they wouldn't have another febrile UTI. So because there was no difference whether you had a VCUG or no VCUG, we concluded that you did not need to do a VCUG after treatment. Next question is open surgery the best method to achieve highest clinical success? And I'll tell you, when I started to do this, I had to compare my data to open surgery time after time after time. And that was really the impetus, to keep on going with something like this. And then we could ask now, and we recently published a paper asking whether or not open surgery should even be considered the gold standard today. So does it give you a higher clinical success? And let's just look at what's happening to open surgery over time. Again, this paper by Mike Garcia at our institution showed that even before the guidelines, even before the articles were published, from 2004 all the way to present, you could see that the rate of open surgery has just slowly decreased over time. And so you could say that the operation that built pediatric urology is dying. It is an art. It certainly is an art. It's something that you need to learn to do because this is a great operation with great results, and every pediatric urologist is going to need to do this. So let's look at long-term data after open surgery. This is the most modern publication from Boston Children's. Caleb Nelson is a colleague, and they looked at 1,000 patients, and they followed them for 3 years. And you can see from this that the risk factors for febrile UTI were being female, having high-grade reflux, having scarring, and having more infections. But if you look at the clinical success rate, it's 94%, really not different than deflux. If you look at radiographic success, it was also not different. So, we've always quoted 95 to 98, and this series showed about 95% success. Let's look at endoscopic treatment. Endoscopic treatment was very popular. It's actually went up in incidence in between 2004 and 2008. It flattened before the guidelines were published, and then after they were published, dropped down like all the other procedures. But endoscopic injection now is more than 50% of all surgical intervention. Let's look at some long-term results of management of reimplantation, deflux injection, and I'll also talk a little bit about robotic surgery. My colleague, John Roth, again, and at the time, his fellow, looked at morbidity of anti-reflux surgery, and they looked at a database system that went over 5 states over the period of 2007 to 2010, and we're able to compare equal numbers of open surgery and endoscopic procedures. The surgical patients tended to be younger, they tended to be more males, and tended to be more publicly insured. But statistically, fewer admissions after deflux, fewer ER visits, and as you may expect, there was more redo surgeries after deflux. It really just depended on the rates. But it was 1% versus 10%, and so a 90% success with endoscopic injection is basically what they're showing here. If you look at some long-term data after deflux, this is a French study. They had 68 patients. They were able to look at them for up to 15 years, and they showed no obstructions, a clinical success rate of 80%. The ones that had recurrent febrile infections, where they tended to have recurrent reflux, and all these recurrences happened within 5 years. So they had a radiographic success of 85%, and showing that the reflux success after deflux is durable. This is our long-term data. We looked at 575 patients. All these patients had pre-op febrile UTIs. We looked at these patients. We wanted to have a minimum 5-year follow-up in these patients. So we had 8.4 years median follow-up. Our reoperation rate, again, was very low, 3%. We had 2 obstructions. But again, we had a clinical success rate of almost 90%. We had a radiographic success rate of 93%. And families love this. It's 96% were either completely satisfied or partially satisfied. And the 2 patients' parents whose kids were obstructed obviously weren't very happy. Let's talk about robotic surgery. Robotic surgery is not done nearly as much in children as it's done in adults, but it's finding its role. I would first point out that if you just look at what's green here, that's surgery on the kidney. That's pretty straightforward, very good results. It's an easier operation. When you start to operate in the pelvis, you're doing complicated surgery. That's definitely more difficult. But my personal experience over the last 4 years is 240 cases. If you look at just robotic ureteral reimplantation, I want to point out that most of my cases are considered to be complex cases: prior deflux, prior surgery, associated periureteral diverticuli, or ectopia. And then I'll also point out that if you look at primary reflux, 1.4% of all my cases are primary. This is clearly showing that endoscopic injection is first-line therapy for me. Let's look at some results. As I said, we don't do a lot of robotic surgery in pediatric urology compared to the adult colleagues. So if you look at this multi-institutional study, which we were part of, we had 260 patients, and we had an 88% radiographic success and 92% clinical success. Again, not different than what I've shown you for open surgery or for endoscopic. Clavien grade complications 3 and below were not that frequent. Then we took the same group of institutions, and we went ahead and did a prospective multi-center study, and 143 patients basically showed the same thing. Our clinical success rate now over 90%, our radiographic success rate over 90%. So what are the long-term consequences, concerns that you should have? And this is part of a talk I usually give to adult urologists. And so, what should you worry about? Well, we talked about recurrent febrile UTIs, recurrent reflux, obstruction, but misdiagnosis is also something that you need to know about. This is what deflux looks like on an ultrasound. You could measure it. We've done that over time, but it looks different on different studies. If you explant a deflux implant, you get microcalcification of the dextranomer. Remember, the hyaluronic acid has been gone. It's been gone after 2 weeks. So this is what the dextranomer looks like. And even though these may look very dense on a CT scan, it's microcalcified. We did this study because I was interested in what the density of deflux was. So we were able to find in our database patients that had deflux that also came to the ER for abdominal pain. And of course, you get a CAT scan now if that happens. And we were able to show that the Hounsfield units for deflux were all under what was considered to be radiopaque. So these were all radiolucent on an X-ray, whereas, as you know, stones could be either radiopaque or radiolucent. Until this patient came along. So this patient was seen in an outside hospital, had this density down in the pelvis. They diagnosed this patient with an appendicolith, but then did a CT scan and then made the second misdiagnosis, which was a stone. The stone was thought to be a bladder diverticulum, which it was not. So bladder diverticulum, stone, appendicolith, 3 misdiagnoses in one patient. This is another patient that had polycystic ovaries. They came to me because of a frantic mother. The girl was 20, had a transvaginal ultrasound, showed this bladder mass. And the mother called me and said, is it possible it's deflux? I said, come on into the office, did an ultrasound, showed the deflux only. And so they were very happy to know it was deflux. So the conclusion of all this is that a history of deflux is probably the best way of knowing if something is a misdiagnosis. So what do parents want for their children? We did a multi-institutional study with our colleagues at Duke, and it was really based on the Amazon Mechanical Turk. Now, I'd say to residents, if you want to get a paper done quickly, use the Amazon Mechanical Turk. It's amazing. I'll show you some more data on it. But we did this best, worst scaling in order to determine what parents want for their children and giving a hypothetical patient. And what they really want is high treatment success. That was most desirable. The doctor recommendation and low complication was relatively important. And then the societal cost, how much insurance pays for it, cosmetic effect, invasiveness. This actually was the least important. Now, this was the study done before that got Duke interested in joining us because we used Amazon Mechanical Turk, another Mike Garcia paper, and we paid 10 cents for them to do the survey. And we got about 60 responses in 2 or 3 days. When we doubled it to 20 cents, we got 1,000 responses within the week. And we asked this question: if you or your child needed to have pelvic surgery and you had this incision versus laparoscopic or robotic ports, which would you choose? Some people don't care, but really you can see that it's really equally split. But when you show them the picture of a garment covering their incision and visible port sites, 30% more chose to have this. Now, as you could imagine, as when I talk about robotic surgery, my colleagues don't like this. And it kind of forced people to say, okay, how can we get these ports somewhere else? So let's do hide surgery. So Patricio Gargolo published papers how you could kind of move those incisions down here. And so there are ways around this, and it allows people to be innovative. So let's go back to the management of my first patient I presented to you. Bilateral high-grade reflux, intrarenal reflux, grade 5 reflux. How would you manage that? If you look in the bladder, and this is the way I designate my patients: right grade 4 reflux, left grade 5, and then hydrodistension grade. How would I treat that? Well, I let the parents decide, and I give them the results of everything. And because this child was under age 1 at the time with breakthrough infections, we went ahead and did a reimplant. So let's talk about, this is really the end here, about individualized surgical approach. And this is how I present reflux and its management to all families I speak to. Open surgery is great. There are more options in approach. You can do it intravesically, you could do it extravesically, you could do cross-trigonally, you could do it ipsilateral reimplant. It certainly has higher morbidity. And for me, I think it's best for the youngest patients with the most complicated anatomy. They typically will go home the next day, but they have a large concealed scar. The success clinically, 94%, radiographically, 95%. Endoscopic injection, in my practice, is first-line surgical therapy for primary reflux. 95% avoid open surgery. It has the lowest morbidity. It's a same-day operation. It has very high parental satisfaction, and there are no scars. And clinical success and radiographic success are both very high. If you look at robotic surgery, these tend to be in older patients with complex anatomy. As I said before, it's an alternative to open surgery. These are ones that have failed deflux or open surgery. They have refluxing megaureters, ectopic ureters, duplications, diverticuli. And even though these patients are older, they tend to go home the next day also. And they have small and concealed scars. And the success rate is 93, 94%. So I presented all surgical approaches and showed basically that the results are the same. So as I would advise people that are going to urology, when there are multiple different treatment options, try to get good at many of them. It gives you more options, it gives you more to discuss with families, and you'll find out which one you do the best and which one you like the best. But keep your mind open, and I wish everybody luck in their careers. I very much appreciate the opportunity to come back to visit everybody, and thank you again.
Thank you, Dr. Kirsch, for this amazing up-to-date review on management and grading and all of the research that you've done. We have quite a bit of questions, so I just want to get through as much as we can before our next speaker. The first question we had is, in your practice, what is the rate of obstruction that you've seen with deflux, and how do you manage it?
Great question. Fortunately, it is low. When we published our obstruction rate early on, it was 0.5%. When I looked at my series, it was 0.3%. How do you manage it? You can manage it, it depends when they come in, right? If it comes in, you're out of town, your patient might get stented, they might get nephrostomy tubes. I think nephrostomy tubes are a good way of doing it because it allows you to assess whether you could take them out or not. If you put a stent in, the only thing you could do is take the stent out and then hope they don't get obstructed again. So I've seen them both. Fortunately, I haven't seen a lot of these patients. I get calls from around the country, but I did have an obstructed patient bilaterally, got bilateral nephrostomy tubes. They had one tube removed after a normal antegrade study. I scheduled them for a unilateral reimplantation. On the day of surgery, I did another antegrade study. It went straight down. I just took out the second tube. But I have done reimplants post, and these are the ones I do robotically. I've had a couple of obstructions longer term. Fortunately, they've been symptomatic. We worry about long-term obstruction after any anti-reflux surgery. But the two cases that I presented were after 2 or 3 years, and they were treated successfully with robotic surgery.
Gotcha. Okay. Well, kind of changing the gears to adults with persistent reflux, whether it's after some kind of reconstructive surgery or ureteral reimplant, does deflux work? Do you know if deflux works for adults, and especially in adults who have, persistent pain secondary to reflux or recurrent episodes of pyelo secondary to reflux? Do you know of any data?
Absolutely. So Terry Hemsel from Columbia was the first to present on the success rate in adults and had a very decent success rate. We went on and did about 60 adults, and the success rate wasn't any different than in children. What's interesting about, you asked about pain. Children don't typically present with pain from reflux. Just the kind of the physical pressure of the urine going up into the kidney is not something kids complain about, but the adolescents and adults do complain of that. And that's something that I've noticed over the years. I think if they have pain, you just want to be certain, that they don't have obstruction. And so I would say it makes a very good treatment option in adults, maybe even better, because these are patients you don't want to do reimplants on, and they have other comorbidities as well. And reimplant in an adult is not a fun, easy operation, but maybe a robotic approach would be better. I saw Carl Olson's picture there a second ago.
Yeah, we have a lot of people tuning in. Let me ask you one more question, Dr. Kirsch, before we transition to our next speaker. One of our pediatric urologists, Dr. Carpenter, is asking are there any ureters that you would deem unsuitable for deflux, meaning, those with minimal intramural tunnels? And if you don't, is there, if they do have a very short tunnel, do you ever alter your technique?
Yeah, very good question. So, the two conditions that I think are not great. One, I think you should change the technique if you see it, is an ectopic ureter to the bladder neck or below. Those refluxing ureters, my success rate was 14%. It wasn't a big series, but if you look in, you could say, well, should I try to do deflux and see what happens or not? I'd say just wait, just change what you do. The other one is the transplant ureter. The transplant ureter is sometimes transplanted into the dome of the bladder. There's no tunnel. It's better to reimplant that patient as well. But with a 50% or lower success rate in that patient population, it's actually worth trying. to do a deflux injection. But if you look at just like the, you're saying if you have a very short tunnel, well, a very short tunnel is the H3 ureter, I would say, and the success is very good with those. It's just going to take a little bit more volume. So most kids, I think, are amenable to deflux. Ectopic ureters, I would say no. Transplant ureters, I would say it's worth a shot.
Great. Well, just due to time, I just want to thank you, Dr. Kirsch, again for joining us for this Empire Lecture Series. It's great to, at least from a resident standpoint, I mean, this is going to be an amazing review for us. If you tuned in late, the lecture will be available online after the session. And again, thank you very much. There's a few more questions, if you don't mind sticking around the chat, that some people have asked.
Sure.
If you could address those, that would be great. But thank you again.